Hello and welcome. I just wanted to record a quick video to help you prepare on some focus areas regarding exam one coming up soon. The first question that I want you to consider is the pathophysiology between sideroblastic and iron deficiency anemias and comparing that. This is something that you saw in your study guide. So remembering that sideroblastic anemias are caused by inadequate iron availability. And this has to do with the impaired incorporation of iron into the hemoglobin itself. And this can be caused by either genetic defects, it can be caused by lead poisoning, and even alcoholism. And what is happening is that these abnormal sideroblasts will accumulate iron inside the mitochondria. And this is because they can't synthesize heme effectively, leading to ineffective erythropoiesis. And with this ineffective erythropoiesis, you end up with iron overload. So, in your patient clinically, you may see some key features like an elevated serum iron, ferritin, and transferrin. You might even see bone marrow showing these ringed sideroblasts. Remember, I said that they were abnormal. They're abnormal erythroid precursors, and so they will be these ringed sideroblasts. So then let's compare iron deficiency anemia. With iron deficiency anemia, it doesn't have to do with the sideroblast itself. So let the name help you, right? So iron deficiency anemia really is because you are not taking enough iron. So there's an inadequate iron intake leading to low iron stores. And this can be due to things like chronic blood loss or even malabsorption of nutritional iron. So the pathophysiology behind this is that there's decreased iron stores resulting in reduced hemoglobin synthesis. Overall, this is going to lead to smaller and hypochromic, meaning very pale red blood cells. And so what you'll see in your CBC with differential is you'll have microcytic homochromic anemia. And so the key clinical features that you'll see on your patient, you will notice in lab, they'll have low serum iron and ferritin and transferrin saturation, elevated total iron binding capacity. And the reason why this is elevated is because it's the binding capacity, the capacity to hold iron. Well, it's elevated because there's not a lot of iron to bind. So that's why there's this elevation. So if we contrast the two with sideroblastic anemia, you're going to see high serum iron, ferritin, and transferrin. And with iron deficiency anemia, you're going to see low serum iron, ferritin, and transferrin. So let's take a quick pause and we are going to look into the predisposition of patients with thrombi and emboli. So I would encourage you to pause and try to recall what you remember regarding this topic before moving forward. Okay, for most patients, having a pre-thrombotic condition predisposes someone to having a thrombi or emboli. So if they have conditions like hypercoagulability, this may cause them to be at more risk for abnormal clot formation. Now, hypercoagulability can occur due to genetic disorders like missing certain blood factors like factor V Leiden or prothrombin mutations. It could also be acquired, though, like through cancer malignancy, pregnancy, even sometimes with oral contraceptive use, you can put yourself in a hypercoagulable state. And this is why we really ask before someone takes oral contraceptives if they've had any issues of blood clots, high blood pressure, or stroke in the past. Also, a vascular injury can predispose someone to thrombi and emboli. If they've had any type of trauma or surgery, or they have atherosclerosis, this could lead or lend to endothelial damage and increases the risk for clotting. And then obviously, if someone is dealing with stasis of blood flow, so that prolonged immobility of blood to flow through effectively. Think of patients that may have heart failure or atrial fibrillation. This could cause blood to become stagnant, and we call this blood stagnation a risk factor for thrombi and emboli. So, stasis of blood flow. Now, before moving on to the next question regarding DIC, try to recall what you remember regarding disseminated intravascular coagulopathy. All right, so my question to you is what's the most common cause of DIC? And really, overall, it's more commonly going to affect patients that have or are in sepsis, and particularly the gram-negative bacteria that are causing the sepsis. Now, infection is going to trigger the release of the inflammatory cytokines. Remember that from previous semester, and it leads to this widespread activation of the coagulation cascade. We have the complement clotting factors, and then we have secondary fibrinolysis. So we're getting fibrin causing that meshwork so that we can have platelets and red blood cells causing clotting to happen. But what happens is over time, all of this is occurring so quickly, and we're trying to clot that we run out of these components that help with the clotting, and then we end up with excessive bleeding. But and that's describing what DIC is and what you might see clinically. But really, the question is, what's the most common cause? It's going to be sepsis, particularly the gram-negative bacteria. Now we're moving on to some characteristics of Hodgkin's lymphoma, excuse me. Now, something very specific to Hodgkin's lymphoma that you may have overlooked in your reading, I encourage you to go back and look and read about the Reed-Sternberg cells. And this is almost diagnostic of a Hodgkin's type lymphoma. And these cells, these Reed-Sternberg cells, they are large, they're multinucleated, and they have this owl-like appearance or owl eye appearance when you look under microscopically. We also see with Hodgkin's lymphoma enlarged, painless lymph nodes. And typically you're going to see it in this neck region, the axilla, and the groin region. So we call that lymphadenopathy. You may recall that from your health assessment class. Now, other features of Hodgkin's lymphoma are what we call the B symptoms. Very important to recall B symptoms. B symptoms include fever, night sweats, and weight loss. Often we see with Hodgkin's that we're going to see a localized effect. It's like a localized effect to a group of lymph nodes. It's not very common that we are going to see all the lymph nodes in your body being affected all at once. Other things, like if we're going to contrast lymphoma, we might as well talk about clinical manifestations of leukemia as well. And leukemia is characterized when we have at least 30% of lymphoblasts in the blood or the bone marrow. And what you might see because of this is bone marrow suppression, organ involvement, and then we'll see systemic symptoms as well. But for the bone marrow suppression, it's going to cause symptoms of anemia. So your patients may feel fatigued, they may look pallorous, and they may be weak. We might also experience thrombocytopenia like bleeding, petechiae, bruising, purpura, and leukopenia. So then this increases their susceptibility to infection. Now, organs that might also be involved, in addition to what we see with bone marrow suppression, is that you might see hepatosplenomegaly. You might also see lymphadenopathy, and this is because leukemic cells are infiltrating. Also, many patients feel bone pain, and this is because the marrow is expanding. And then the systemic symptoms that I was alluding to earlier were fever, weight loss, and night sweats. So this is in similarity to what you might see with patients that are dealing with some of the lymphomas. The last question that I want to talk about is carcinogenesis of oncogenic viruses. Now, what does that mean? Well, oncogenic viruses contribute to cancer development, and these are altered by the host cell's DNA. So, some examples of oncogenic viruses might be HPV or the human papillomavirus. And we see this through the inactivation of tumor suppressor genes. We also would include in this category Epstein-Barr virus or EBV, promoting B cell proliferation and survival. Epstein-Barr virus is often also linked to Burkitt's lymphoma. So that's a connection you can make. And then hepatitis B and C are caused by chronic inflammation as well as oxidative stress. And this promotes hepatocellular carcinoma. So patients that have Hep B and Hep C are at very high risk for these types of liver cancers. So again, this is considering oncogenic viruses that contribute to cancer development. The virus itself is not cancerous, but it can contribute to the development of cancer.